Thank you for asking me to present a lecture on clinical toxinology as part of your medical meeting. Firstly, an introduction. What is clinical toxinology? Well, toxinology is a science of toxic substances, and that includes things such as venom, poisons, produced by living organisms, and that's the key. They have to be living organisms, things such as snakes, spiders, jellyfish, mushrooms, plants, and bacteria. Clinical toxinology, logically, is that specialised area of medicine which deals with the medical effects of these toxins. In particular, it deals with things such as snakebite, spider bite, marine envenoming, and poisoning from plants and mushrooms. What it doesn't include is toxin-producing bacteria, illnesses produced by those bacteria, such as tetanus, botulinum poisoning, etc. That's usually dealt with by experts in infectious diseases or medical microbiologists. There is a huge diversity of animals, let alone plants and mushrooms, that can produce toxins in one way or another. Starting with the most primitive, the sponges, and working through a variety of so-called lower group animals, the cnidarians, things like the jellyfish of various sorts and hydrozoans and sea anemones, then on to the mollusks, cephalopods, things like the blue-ringed octopus, the snails and particularly cone snails, and of course the various shellfish which are poisonous to eat, not because they produce the poison but because they're taken up from the environment. Then we move on to the slightly more advanced animals, the arthropods. We have the crustaceans such as crabs, the various arachnids such as spiders and scorpions, a very important form of envenoming. Myriapods, the millipedes, other myriapods such as the centipedes, which can give a venomous bite. And of course the vast group of insects, the hexapods, a number of which, particularly the Hymenoptera, bees, ants and wasps, can give a venomous sting. Then we move on to the echinoderms, various starfish, sea urchins and holothurians that have venom production or can be poisonous to eat. And lastly, the most advanced group, the vertebrates, including the fish, and there are a whole host of fish, both cartilaginous fish such as the stingrays, bony fish such as the butterfly cod, the stonefish, etc., which have venomous spines, and the many fish which take up tetrodotoxin or ciguatera from the environment and become poisonous to eat. Amongst the amphibians, a number produce toxic substances in skin secretions, things like the poison dart frogs. Reptiles, obviously snakes as the predominant group there, and there are actually birds in New Guinea which produce toxins, and some mammals such as the Australian platypus that have venom glands and can envenom. You can see in the darkened area that many of these groups have significant impact on humanity, and quite a number have the capacity to kill humans using these toxins. Clinical toxinology is not an area of medicine that has enjoyed a great deal of involvement from the general medical community, but toxin-induced diseases, again excluding those of bacterial origin, affect many millions of people annually. The most important, based on numbers and severity, are, in order of importance, snakebite, way out on top, then scorpion stings, spider bites, various forms of marine poisoning, and then marine envenoming. Toxin-induced diseases involving envenoming and poisoning are now recognised as a significant global health issue, but too often they are still ignored and certainly have been up until very recent times. Snakebite, as I mentioned before, is the most important form of envenoming and particularly affects the rural poor in tropical and developing countries. It is arguably a neglected tropical disease and has only just this year been added to the World Health Organization list of NTDs. It's arguably the most neglected NTD, and if we look at just some of those in terms of the number of people they impact per year, you can see at the side of the slide the various NTDs that have relatively small numbers compared to snakebite. Snakebite affects vastly more people than many of these NTDs. Of course, that means that other forms of envenoming, other than snakebite, things like scorpion sting, etc., plant and mushroom poisoning, have even less attention paid to them, unfortunately. So snakebite is the most important issue in clinical toxinology, and it's now recognised by the WHO as an NTD. It affects maybe as many as 5 million people, new cases per year. It causes around about 400,000 cases of amputations every year, at least 100,000, possibly as much as 200,000 deaths per year, and has a huge social and economic impact, which is often forgotten, but undoubtedly accounts for billions of dollars annually, and particularly in poor rural nations in the tropics, where it affects people at a family and community level to a great extent. In fact, in most of these countries, including Myanmar, snakebite is predominantly an occupational disease affecting farmers. So let's have a look at snakebite in more detail. There are over 3,000 species of snakes currently recognised, of which less than 1,000 produce venom and less than 500 can cause venom-induced disease from bites. And there are two major groups, and I stress that these are not the only types of venomous snake, but these are the two major groups. Firstly, the viperids or vipers, including pit vipers. These snakes have fangs on mobile maxillae, so the fang can be rotated out, allowing it to grow much longer. They're a major cause of snakebite throughout the world except in Australia. And there are a number of examples such as Russell's viper, well known to you here in Myanmar, and South American rattlesnakes throughout South America, and a number of other species of importance. The second major family is the elapids, family Elapidae, which includes the cobras, kraits, coral snakes, sea snakes, and the Australian land snakes. They also have a fang at the front of the mouth, but the maxilla is minimally mobile, and that limits the length of the fang, so fangs tend to be smaller. And perhaps as a consequence, the venom of many elapid snakes is often more potent than that of many, but not all, viperid snakes. Some examples would be the monocelate cobra, which can cause paralysis and local necrosis, well known to you here in Myanmar. And close to Australia, the New Guinea taipan, which causes a variety of systemic effects and is the major lethal cause of snakebite in PNG. Now to cover a few misconceptions. Many textbooks that have been published in the past tend to classify venomous snakes as vipers that cause local effects and bleeding problems, and elapids that cause minimal local effects and paralysis. As I hope many of you already know, this is an inaccurate oversimplification, and it really does interfere with correct diagnosis and treatment. For each snake or group of snakes, there may be a particular pattern of clinical effects, and we have to remember about venom variability, which will result in variations even within a single species of snake in terms of clinical presentation. The other thing to remember is that for many snakes, a bite does not necessarily result in injection of venom, and therefore we have the phenomenon of dry bites, which for some types of snakes can be a very high rate of bites. It's important to understand that dry bite rate in assessing the effectiveness of first aid and of medical treatment. Venoms are very complex. They always contain many different substances. Some of those substances have a single action, some have multiple, quite distinct and different actions. The easiest way to think about it is in terms of what effects they're likely to cause in an envenomed human. So some neurotoxins will affect the neuromuscular junction, causing a progressive, descending flaccid paralysis. And that can be, for most of these snakes, pre- and or postsynaptic in effect. Some other venomous animals can cause neuroexcitation, particularly spiders, scorpions, some insects and jellyfish, but it's not so much of an issue for snakes. Next we have toxins that affect skeletal muscle, the so-called myotoxins, and many but not all of those tend to cause systemic muscle damage rather than local muscle damage. A favourite effect of many snake venoms is on hemostasis, in most cases causing increased bleeding, but with a few cases such as some of the Caribbean vipers causing clotting and DVT, stroke, etc. problems. However, those causing increased bleeding include procoagulants that consume fibrinogen, anticoagulants that block activation of clotting, and these can both cause profound bleeding problems. We also think there's a relationship between these components and the development of microangiopathic hemolytic anemia. Some snakes have hemorrhagens that directly damage blood vessels, and the combination of these plus agents that reduce clotting can cause quite profound local and generalized bleeding. Some snakes have nephrotoxins, either indirect or, for some species, such as Brussels viper, direct nephrotoxins that damage the kidneys. Then there are necrotoxins that cause local tissue damage at the bite site, and a whole variety of other toxins, which I'm not going to go into today. In terms of clinical effects of snakebite, there are two broad areas of pathology that we need to consider. Firstly, there are local effects, and they can vary from almost no effect, even though the bite can end up being potentially lethal, through to major local effects. And for some snakes, it is the local effects which are of medical importance rather than systemic effects. A few snakes, namely the spitting cobras in Africa and parts of Asia, can spit venom directly into the eye of a victim and cause local problems there, but that does not cause envenoming. So moving on from the local effects of venom, we have some non-specific systemic effects. Again, they can vary from nothing through to the common features: vomiting, headache, shock is certainly possible, collapse, for some snakes convulsions, even cardiac arrest. These effects tend to occur as the venom reaches the bloodstream, so it gets generally circulated throughout the body. Once it's in the bloodstream, some venom components will have reached their specific targets. And that, of course, are those components, those toxins, that interfere with blood clotting or cause thrombosis or damage red cells, damage platelets, damage blood vessel walls, etc. However, a number of components have to reach the extravascular compartment to reach their target site, and that includes toxins that cause paralysis, muscle damage, kidney damage, heart damage, etc. This diagram is just another way of thinking about this whole process. So first of all, venom is injected locally at the bite site, and for some components that is where it will have its major action. Venom which is absorbed from the bite site travels to the central circulation, often via the lymphatic system, and so may show up with swelling or tender lymph nodes, an important clinical sign when you're looking at a snakebite patient. Once it's reached the bloodstream, it will be in the intravascular space where a variety of components will have their targets. Coagulation cascade causing coagulopathy, high white count, a low lymphocyte count, thrombocytopenia, in some cases intravascular hemolysis. From there, it may distribute out to the extravascular space where it may reach the neuromuscular junction, targeting both the presynaptic area, the terminal axon, and the postsynaptic area, the muscle end plate, to cause that flaccid descending paralysis. May target skeletal muscle, causing myelitis. May target the kidney, causing acute kidney damage, quite often acute tubular necrosis. And the consequent effects can be bleeding or even cardiac arrest, flaccid paralysis, which may lead to respiratory failure, kidney failure with oliguria or anuria as the common clinical symptom, and muscle destruction with muscle pain, weakness, myoglobinuria, which looks like hematuria, and a raised CK. The obvious local effect that we are concerned about is local necrosis, as seen here in a Russell's viper bite. And the systemic effects, and in your country probably the most important, is acute kidney injury, often as a result of Russell's viper bite. So how should we respond to snakebite? First aid in snakebite can be life-saving if used correctly. But unfortunately, many forms of first aid that are commonly practiced are used inappropriately, are ineffective, or actually dangerous, and may put the patient at increased risk. So things like tourniquets, snake stones, cut and suck or scarification, or the suction devices used in America, electric shock, are all first aid methods which should not be used. Also, reliance on traditional healers and their techniques has the potential to worsen outcomes. It can delay definitive treatment, and it can introduce potentially dangerous treatments. But let us not forget that maybe with the right approach, traditional healers could become our allies in better managing snakebite pre-hospital. Antivenom is the specific antidote for snakebite. It's made by hyperimmunizing animals, and in most places that means horses, against a particular venom, in this case snake venoms, and harvesting IgG antibodies from the blood of these snakes and refining that into the antivenom. So the horse is not usually killed in this process. It starts with collecting venom from the snake. That's a very important part of the process. The venom is injected into the animal that's being used. As I said, horses most often used. The horses become regular blood donors. That blood is then fractionated to take off the antibody component, checked for activity, checked for safety, and then bottled and made available. By definition, antivenom is raised against the venoms used in immunizing the animal. Therefore, it may not be effective against the venom of some different type of snake. And it's very important to understand that, because you have to use the right antivenom to have a useful effect. We also have to remember that even within a single species of snake, across a wide geographic range, there may be variation in venom. So that the venom from one part of the range may be quite different to that from another part of the range. This is, in all probability, true for Russell's viper just within Myanmar, and certainly true for Russell's viper throughout its range in the Asian region. Antivenoms require significant expenditure to make. They're not cheap drugs to make. And they only tend to work well when they're given very early, as soon as the indication is there. However, because they are animal-derived, they can have severe adverse effects, anaphylaxis and serum sickness being two of the most important. And so every time you give antivenom, you must be prepared with adrenaline and resuscitation equipment at the ready, so that you can treat the patient if they develop these problems. Unfortunately, throughout the tropical world, where snakebite tends to have the highest incidence, antivenoms can be difficult to obtain or are too expensive for people to afford. This is especially true in sub-Saharan Africa, where there is a current antivenom crisis. but it's also true in parts of Asia. I have to say, however, in Myanmar, people have had reasonable access to antivenom, and it is now freely available. So a number of those blocks to seeking antivenom treatment from the health system should not be occurring in your country. We do know that some antivenom producers unscrupulously sell inappropriate antivenoms outside of their proper market. This applies to antivenom producers in one country in Asia selling their product into Africa, where it has no benefit and significant adverse effects. So what are some snakebite issues, factors that affect the impact of snakebite? First of all, the level of community knowledge about prevention and treatment of snakebite is very important. Do the people who are at risk of snakebite understand what those risks are? Do they understand the need for urgent health care? Do they understand how to prevent being bitten in the first place? What is the availability of those healthcare facilities? And do they have access to appropriate staff and resources such as antivenom to rapidly treat snakebite? Can patients afford the treatment costs? I hope that's not an issue in Myanmar, but it certainly is in many other countries. Can patients afford the transport costs and the costs of their family looking after them in hospital if they've had a significant snakebite? That is an issue almost everywhere, and certainly even within Myanmar. What about antivenom availability, its quality, its effectiveness? What about the role of traditional healers? Are they delaying effective treatment? Are they using damaging treatments? But as I mentioned earlier, even if they are doing these things, can we retrain them so that they apply appropriate first aid and they become part of that pre-hospital treatment process? Turn them from a potential problem into an ally. So what about clinical toxinology and its relevance in your country, Myanmar? Well, as I'm sure you all know, you have a long documented problem with snakebite. It's been a major problem impacting the health system for a very long period of time, certainly as long as we have reasonable data, which is over many, many decades. Current data indicates around 15,000 cases of snakebite per year, with around 600 deaths per year. However, that figure is generated from hospital data, and we know from many studies around the world that hospital data is not a really good source of such information, particularly for snakebite. Community studies are far more relevant, and we know from the Indian study, their million death study, that they found an actual mortality rate from snakebite in excess of 45,000 cases per year, even though the hospital data indicated just a few thousand cases per year. If we were to extrapolate the data from India to Myanmar, and remember the environment and even the snake fauna is not particularly different. It is different, but it has a lot of similarities. That could give us a figure of around 2,000 deaths per year. I suspect it may even be higher than that. So what can you do to improve the situation? Well, the starting point is to draw on your own long history and contributions. There's no question that within DMR and elsewhere within your country, there have been notable scientists and doctors making important contributions. Don't ever forget the work that your own people have done. You also have a long and honoured history of antivenom production in Myanmar, so you've got a really good starting point. I think some of the next steps to consider would be the government declaring snakebite a national health priority, establish comprehensive training schemes, and effective and universal education for at-risk populations. The ultimate aim, I think, is to establish Myanmar as a regional leader in toxinology, continuously monitoring incidents and outcomes of snakebite. So what about training for snakebite? Some of the curriculum main elements are listed on this slide. You need to understand what the snake fauna is, what the dangerous species and how to tell them apart from the harmless species. What human behaviours increase the risk? What about prevention? What does the venom contain? What does it do? What are the clinical effects? What is appropriate first aid and pre-hospital response? And what, in detail, are the hospital responses in terms of immediate assessment, emergency care, choice of antivenom, long-term care and rehabilitation? You also need to consider epidemiology and the socio-economic effects of snakebite and understand research methodology in snakebite that can help you expand your knowledge to further improve outcomes. I will be proposing to your health system a coordinated training scheme that covers the entire community, from the highest level right down through master trainers to second tier trainers, training people within the university system, so medical students, nursing students, etc. A very important role for your universities of medicine, of nursing, etc. Within the health system, training qualified doctors, and in the community, training the community on prevention and pre-hospital care. I think you should take a holistic approach. There are many elements involved in achieving these aims. You need to better understand the risk burden and define ways of dealing with that. You need to promote prevention strategies, and you need to up-resource your health system to make sure at all levels it can adequately and appropriately deal with snakebite to produce good outcomes. Lastly, I will briefly mention the Myanmar Snakebite project. And this initial slide just shows three of the people involved, of the many. Dr. Ong Zaw, who's now the factory manager for Burma Pharmaceutical Industries, who produced the antivenom. My colleague, Dr. Chen Ao Pei, nephrologist from Adelaide, who is the leader of the project. And Dr. John Moody, one of the staff from CSL, Australia's antivenom producer in Melbourne. John is a vet and has certainly contributed. And this shows the breadth and scope of the project. It's a project which was funded by the Australian government, and we are trying to have a holistic and collaborative approach which very much relies on working with our colleagues in Myanmar. The lead partners in Australia are run through the University of Adelaide, but involving also the University of Sydney, CSL Limited, CSIRO, Animal Health Laboratories, Venom Supplies, etc. And in Myanmar, the Ministry of Industry and the Ministry of Health and Sports. Our consultant staff from Australia largely provide their time as in kind through their regular work or personal time, and we've got experts in a whole variety of areas to strengthen knowledge, strengthen what we can do within the project. We also employ people within your country who we hope, at least some of whom, will go on to a longer term career in toxinology in your country, supporting your people. There are three project focus areas: improving the quantity and quality of antivenom, give Myanmar sustainability again, improve the distribution of the antivenom, and improve management of snakebite at all levels. To this we can add epidemiologic studies, collection of detailed prospective case data, and promotion of those prevention strategies. I've only got time to talk about a very few of our outcomes, so let's look at antivenom, and specifically the horse component. As I mentioned, horses are vital. They're hyperimmunised with venom, and they're the basis of antivenom production. But when we started the project, horse survival at BPI was at crisis point. So we brought in vets and others to advise on ways to improve survival, with recommendations which were implemented by BPI on a progressive basis, and there is a result, a massive fall in horse mortality of about 95%. This has an enormous impact on BPI. It reduces cost. It makes it possible for them to produce much more antivenom. It's a major benefit. Are there other things we need to do with antivenom? Absolutely. And we're moving towards those now. Second area to mention is the health system response to snakebite. We've been involved in training in our project area, Mandalay, with new training and treatment resource materials. Antivenom supplies have been increased and switched entirely to BPI away from Indian. Community surveys have been performed, and as some of you will know, we already have this collection of detailed hospital case data. This is one of the resource materials that we've provided. This is the diagnostic and initial management algorithm, which is progressively being rolled out, I believe, now countrywide. It was based on work done by you, Myanmar doctors, using some of the expertise that we have from outside to put that into this form. In terms of hospital case data collection, we built custom databases to contain this information. We now use those to quiz them 3 monthly to provide data for all the participating hospitals on what's happened in the previous 3 months with snakebite cases, make that available to the Ministry of Health to enable them to plan. We have the first full year's data from Adelaide General Hospital, and of course the number of other hospitals is rapidly expanding. But in that first year in Mandalay alone, we had nearly 1,000 cases, Brussels viper dominating, and a disturbingly high mortality rate. This is the data, first page of the data form that we use, and we hope that this will all be possible to enter online in the very near future. Lastly, I proposed an idea earlier this year of a Myanmar-Australia Institute for Health Development. It's only an idea at present, but such an institute could, if formed, promote health development in specific targeted areas such as snakebite, help establish long-term links between Myanmar and Australia, with an aim to make Myanmar a respected top-level contributor to health expertise and development in the Asian region. Bring it back to where your country used to be decades ago. And this diagram just shows the interrelationship. Such an institute will interrelate with universities, government, NGOs, etc. within Myanmar, within Australia and beyond. At that point, I'll finish. Thank you for allowing me to talk at your meeting, and my apologies for not being here in person.